So this is case number 1, case of Mr. B. We're dispatched to his residence. This is for a 72-year-old male patient who is short of breath. Our page time is 5:52. So we arrive and we find Mr. B sitting up in a chair. He's alert and he's got a very fast breathing rate with wheezes that we can hear even as we're approaching him from across the room. He can get 3 words out per breath. He has a rapid, strong radial pulse. His skin is pink, warm, and wet. On history, we find that this patient complains of having been up all night, feeling short of breath, started at 10 o'clock last night. He has been using his nebulizer machine with a medication of albuterol. He's got a productive cough. He's bringing up a thick, dark yellow sputum. He says he's very tired. Patient has a history of chronic obstructive pulmonary disease, reactive airway disease, actually asthma, congestive heart failure, diabetes mellitus, and hypertension. His diabetes, he's actually a type 2 diabetic. He takes glyburide for that, and he takes prednisone for his COPD and his reactive airway disease, as well as the use of inhalers. He's on lisinopril and Lasix, both medications that help with his congestive heart failure. The nebs he uses are albuterol, Atrovent, and metoprolol, and he also has a rescue inhaler of albuterol. He has no known drug allergy. Mr. B is not using accessory muscles this morning. His breath sounds are inspiratory and expiratory wheezes. We can hear that audible in all fields. We also can detect on both sides a little rattle in the bronchi, which we call rattle in the bronchi, which is bronchi. He's got no jugular venous distension, but he does have just a little bit of ankle edema. So vital signs, most pronounced is his tachypnea, his rapid breathing at a rate of 40. He's also got a pulse of 120 and blood pressure of 180 over 110. This was the EKG that was obtained, showing a sinus tachycardia without any ectopy. So our care for this person at this point was, so we had him on oxygen. We started an albuterol nebulizer. We placed an IV. In this particular case, we did not give him a fluid bolus. That would be another important consideration for any patient who has been short of breath for a period of time. Particular asthma responds well to IV fluid because you want to keep them well hydrated. The patient was transported sitting up. He had a 4-minute trip to the hospital. We went with siren. On the way there, we reassessed his breath sounds, thought they sounded about the same. His O2 saturation was showing 98% as he finished that nebulizer, and his respirations were 28. Once in the emergency department, Mr. B received another nebulizer, this time albuterol with Atrovent. The combination tends to work pretty well. And they did a chest x-ray. That showed no infiltration, which is a way of saying that he doesn't have bad pneumonia. He received an IV medication called aminophylline, and that seemed to give him considerable relief. He was observed for about 3.5 hours while they were talking about admitting him, and decided that they would just keep him under observation for a while. The patient wanted to go home. He received 3 more albuterol nebs. So what is aminophylline? Aminophylline is a xanthine alkaloid derivative. And xanthine alkaloids are naturally occurring chemicals that inhibit adenosine in the cells, and they're a mild stimulant. Xanthine alkaloid also inhibits phosphodiesterase, which is part of your immune response. So it's an anti-inflammatory, very similar to ibuprofen. It is a bronchial muscle relaxant. And other xanthine alkaloids that you're familiar with are theobromine and caffeine, which are found in tea and coffee. Mr. B remained with a little expiratory wheeze. Physicians decided that was probably going to be his baseline and is his baseline. They determined blood gases that were drawn. These were what we found. PaO2 was 62. Normal PaO2 is that's right in the middle of the normal PaO2 range. A pH should be between 7.35 and 7.45, and they got 7.48. So he's a little on the alkalotic side, a little on the base side. His PCO2 is 32. That range is 20 to 40 normally, and so it's a little bit in the right half of that. So this person basically has been blowing off a little CO2, but still has some retained, and as a result, that's brought his pH down or pH up just a little bit. His O2 saturation is 93% after having been off oxygen for a half hour. He received another COMBIVENT, then sent home as he requested. He has 2 new prescriptions. He's on Theodore, which is in fact aminophylline in a pill, an oral pill. So Theodore is another xanthine alkaloid derivative. And he's on Bactrim, which is a wide-spectrum antibiotic designed to help his flare-up of bronchitis, killing any bacteria that might be causing that, or at least helping to reduce the presence of bacteria. So this is a good opportunity to talk about what COPD is. It affects 17 million Americans. Smoking is the most prevalent factor, but other pollutants are, and it can be first-hand smoke or second-hand smoke. It involves a triad of conditions that you probably have heard about. The most common is chronic bronchitis, and then emphysema and asthma. We don't typically think of asthma as a COPD because asthma can be can be a disease entity by itself. But in all cases, there is some type of obstruction going on, and these are chronic conditions. There's a patient now who's in a tripod position, classic. You'll notice he also has pursed lips. Like most people with COPD, he's trying to keep his airways open, and he's trying to keep his alveoli a little bit distended. And the pursed lips provide positive end expiratory pressure. So there's little resistance at the very end of each exhalation. This is very similar to the effects that we want when we administer CPAP. Chronic bronchitis is an inflammation of the bronchial tree with significant mucus production. That is why they have a productive cough, and by definition, a person has chronic bronchitis when they've had that productive cough 3 months out of the year for 2 consecutive years or more. Again, 3 months out of the year and 2 consecutive years or more. The diagram that I'm showing here shows the inflammatory response of the body and the thickening of the basement membrane of the bronchi. And this is exactly why they're so resistant to exhalation and inhalation. But the main problem now is on top of that, and on top of this inflammation, we're producing a lot of mucus in an attempt to fight off recurring infections. So the comparison here of a normal bronchial tube and a bronchitis patient, with the main difference being the inflammation of the epithelium and the large production of mucus that accumulates in the bronchial tubes. Emphysema is a late stage of chronic obstructive pulmonary disease. Some of these patients also have asthma, some of these patients also have chronic bronchitis, and some patients just have emphysema. Emphysema is marked by a decreased elasticity of the alveoli. So you're actually affecting the alveoli and not just the air passageway in. However, the bronchioles do tend to constrict, and often they constrict deliberately to try to maintain some pressure in the alveoli so they don't collapse completely. Because the alveoli are breaking apart, actually becoming fragile, these are patients who may have decreased diffusion of gases. That is going to be why they retain carbon dioxide in the bloodstream. They get these formations called bulla. And what that means is that the alveoli are kind of breaking into larger passages of air. And so instead of having 100 little alveoli in a small area, you look in that same area and it's like you've got 1, 2, or 3 of these large formations of consolidated air masses. And so this results in air trapping. It also really increases their risk for pneumonia, and as those things pop, they may even get a pneumothorax. Here's a side-by-side comparison of slides of lung tissue. The one on the left is a healthy lung. The one on the right is somebody with emphysema. And as you can see, because of this reformation of the lungs, you actually have a lot less surface area to have diffusion of gases into the bloodstream. Many of these patients are going to be on oxygen. To get oxygen, a person has to have chronic hypoxemia. That means a low level of oxygen in the blood, but defined as less than 55 millimeters of mercury, or a O2 sat that is chronically less than 90%. The goal of treatment for home oxygen is to try to keep that O2 sat over 90%, or the PaO2 greater than 60. Asthma. Asthma, also known as reactive airway disease, affects 15 million Americans, and it is responsible for up to 5,000 deaths every year in the United States. People who have asthma have acute episodes. These are attacks that come on because of a trigger. The triggers can be extrinsic or intrinsic. A severe asthma attack that is not easily treated with our standard bronchodilators is referred to as status asthmaticus, and this is a true emergency. Asthma is chronic inflammatory disorder of the airways. The airflow obstruction results in a hyperresonance and can usually be treated. However, the difficulty that these people have is on a prolonged exhalation. Triggers vary between people, and some it's an environmental thing, others it's exercise, and for others it could be food, medications, and a trigger can actually even be stress or emotional upset. When we have an acute reaction of asthma, it comes in two phases. The first phase starts right away, and this is caused by the release of histamine. Histamine contracts bronchial muscles. It stimulates a constriction of those muscles and tightening of the bronchial tubes. There is a leakage of fluid from the bronchial capillaries, and that begins bronchial edema. During phase 2, which is usually 6 to 8 hours later, we see continuing inflammation of the bronchioles, and the immune system cells start to invade and start to produce mucus. We have additional swelling of the bronchioles as a result. So again, here's that comparison. You can see that there's some similarities with chronic obstructive lung disease, chronic bronchitis, but the thing about asthma is it affects both lungs about the same, and it's caused by a trigger, not an infection. Many people who have asthma will be measuring their ability to exhale and inhale using a peak expiratory flow measurement. This actually allows them to measure how much air they're able to move per breath. We typically do not employ this as a way of evaluating the patient. It has been recommended to be used as a way of measuring your improvement after treatment. However, another tool that is becoming much more commonly used and quite helpful is the capnograph. So by using capnography, end-tidal CO2 measurements, putting a little cannula under their nose that can go to your cardiac monitor with the CO2 monitor, we'll be able to actually see the pattern of their breathing. That prolonged expiration is very visible in the form of a shark fin pattern. So you can see here a comparison of a normal capnography with the capnography of a patient who has asthma. Asthma results in increased resistance to moving air. So air tends to get trapped into the lungs as they breathe in with air hunger. This results in an increased pressure in the chest. That increased pressure in the chest can decrease the amount of blood now going back to the left ventricle because of the pressure it has to overcome to get there. That means less preload of the ventricles before they contract, and that can mean less cardiac output or even a drop in blood pressure of some significance. I'm going to ask you now to go ahead and take the case number 1 quiz, and then we'll come back and talk about case number 2.